Good morning. My name's Alan Weil. I'm Editor-in-Chief of Health Affairs. It's my pleasure today to kick off our event focusing on the December 2016 issue of Health Affairs, which has a major cluster of articles on oral health and a few other tidbits as well for those of you who look through the entire issue. It's, I think, not just a pleasure, but really important for us to be releasing this issue that focuses on oral health. It is often viewed as forgotten. It often is not a part of the core healthcare conversation, and we hope at Health Affairs, by having an issue focused on this topic, that we are able to increase the profile of the issue, both as oral health an issue in its own right, as well as the relationship between oral health and physical health. And we have papers in the issue that do both of those things. We are, of course, at a time where there's certain to be significant discussion about the future of health policy broadly. There are changes in the financing and coverage elements of the oral health enterprise that have been put into place, and their future is, I think, going to be debated, and we hope that the papers here can help contribute to that. The way we do these, for those of you who have not been to a release event before, I'm going to kick off with a more of a conversation style with our first two panelists, who I'll introduce in a moment. We'll move directly into a series of panels where authors of papers in the issue will have the opportunity to present their findings. After our opening and the first panel, we'll take a break and we'll reconvene. I run a tight ship, and we'll get you out of here on time as advertised. As we get started, I do want to acknowledge we received support from a number of funders that made this issue possible. The California Wellness Foundation, the DentaQuest Foundation, the American Dental Education Association, the Reach Healthcare Foundation, the Washington Dental Service Foundation, the Gary and Mary West Foundation, the American Dental Association Health Policy Institute, the Pew Charitable Trusts, and the St. David's Foundation. And if you had trouble following all those, all of their names and logos are up on the screen, and it's probably a little easier to see that than it is to keep track of all that I had to say. To frame our discussion today, I'm going to have a session here that will include Rich Manski. To my left, he's professor and chairman of dental public health at the University of Maryland School of Dentistry, a senior scholar at the Agency for Healthcare Research and Quality in the U.S. Department of Health and Human Services. I particularly want to call out that he was our theme advisor for this issue, overseeing and helping us with all of the review of these papers. Beth Mertz, associate professor at the University of California, San Francisco, has a joint appointment in the Department of Preventive and Restorative Dental Sciences, School of Dentistry, and in the Department of Social and Behavioral Sciences in the School of Nursing there. She has actually two papers in the issue, one of which she'll present formally later, but also provides an overview about a topic that I called out as a theme for this issue, not, of course, the first to note it, about the dental medical divide. And so I'm going to sit and get a little conversation going, have Beth give you a little bit of the history, turn to Rich for a little bit of the current, and then we'll go into a discussion. So this is my formal transition to a discussion. Okay, how'd that go?
All right.
So I'm going to, Beth, I'm going to ask you just to walk us through three elements of the dental medical divide that I think came out in your paper. You focused on the profession side, you focused on the financing side, and on the research and quality side. And I'm just going to ask you to sort of take a couple of minutes on each of those to give us a sense of particularly the historical origins, which I think are maybe not known to everyone.
Okay, sure. Can everyone hear? Good morning, everyone. Thanks for having me. So when we say historical, let's just preface this with going back to maybe about 1900. So we're not going back to long times ago. So I'm sure that
before the internet.
Pre-internet. Yes, exactly. So when we think about the professions, we know that in dentistry we have dentists, dental hygienists, dental assistants, kind of the core dental team. And then today they're educated often in academic health centers and throughout the community system. But historically, when we look at that, when the first medical schools were being established in the United States, dentistry was not included. And there is a different model in other countries that's used, which is called stomatology, which is essentially a dental physician. So it's a physician that focuses on dentistry, on oral health. But that really didn't happen in the United States. Many of you may be aware that the Abraham Flexner report really became the architecture for medical education. And when that happened, the Carnegie Foundation was approached to then do a similar report for dentistry, and that became the Geis report. The Geis report then became the architecture for dental education. And in that process, even though there was still a debate at the time as to whether dentistry should be part of medicine or be a separation, the fact that those two reports really codified the educational systems for those two systems really cemented the separation of dentistry from medicine and really separated that professional division. So then things moved forward, and dentistry often just repeated what medicine did. So there are large schools, academic health centers, professional training, the development of regulatory systems, dental boards in states, and so on and so forth. Everything pretty much mirrored what was happening in medicine, but it was really parallel. And then for the dental team, you see that dental hygienists came about around early 1900s, and dental assistants really evolved from sort of a nursing model, really, but then really tied itself to dentistry. And then, and actually, they're educated separately from dentists. So dental hygienists and dental assistants oftentimes dentists don't even work with them until they go into practice. They don't have a lot of it, unlike in a hospital where providers work together. So I think that pretty much covers the history in terms of we've got the team and how they've been developed over time, and then the a relationship, I think, sort of parallels medicine, but parallels in a silo.
So let's bring in the financing and coverage side.
Yes. So this is, okay, so we're not going to go back as far. We'll just go back to 1965. So Medicaid and Medicare, I think, sort of the start of the current financing system, and then, well, even to the GI Bill and sort of looking at the development of private insurance and the hospital insurance and so forth. Really, dental insurance was a separate, standalone piece, and it came much later than the initiation of hospital insurance. Medicare does not, as you will hear from many of our speakers today, does not include dental. Medicaid did include dental, however, only for children. So adults, it's an optional. So that, again, really cemented the separation and the lack of parity in oral health in terms of policy and financing, because while the rest of the health services were being developed into a bundled insurance package, you really have dental as this standalone, kind of a pre-tax benefit form, not to pay for preventive services, but really in no way is it an insurance program. It's really just a benefit program. And even now today with the Affordable Care Act, what you see is that it's offered in the exchanges, but it's often offered as a standalone, and that the uptake has been very low in terms of folks taking it up, because there's no penalty for not taking it up, even though it's essential.
And then I was particularly struck by your comments on research and the quality enterprise, if you could just give us a sense of the division there.
Yes, absolutely. This is my favorite area, actually. So, in the research area, we're very lucky to have NIDCR. I think we have a couple of our representatives here, which is really focused on dental research, which really means that there's always resources that are really given to that. However, it's been really on basic research, clinical research, and so forth, and the health services research side, which really is what drives the form of the delivery system and understanding how the delivery system is evolving to meet patient and population health needs. There's very little there, and there's a couple of key things that are, I think, one of the root of that. One is that there are no diagnostic codes in dentistry that are being, they exist now, which is great, but they're not being utilized, and they're not being utilized in the payment or delivery of care. So we can't do some basic things like comparative effectiveness research that have been the hallmark of health services research. Also, we don't have mandated or integrated electronic health records. So many of the types of research that we're seeing in hospitals and health systems today, we really can't do in dentistry because it's just a black box. We just don't know, we don't actually know what's happening out there in the delivery system. We're really limited to claims data, which tells us what treatments were provided, and to utilization data, which tells us if somebody went to the dentist or not, but it doesn't give us any insight at all into actually what's happening. And even for the electronic health records that are produced by the same manufacturer that does a medical record and a dental record, the manufacturers don't create those to talk to each other. So even though they're in the same manufacturing, that we don't even have interoperability within a single system. So there's some really large challenges where we have a really amazing set of basic science and clinical research, but really not the ability to translate that from a health services perspective into delivery system reform.
Great. Well, with that as sort of where we've been, Rich, I'm going to have you launch us into where we're going, and you had a bird's eye view on the issue, so I'm going to ask you to take it from here.
Thank you so much, Beth. Very nice. It's important to take a look back. What I'd like to do is take a look forward. I would like to thank you, Alan, and thank the entire Health Affairs team for this very important issue. And I'd like to thank each of you here who took the time to come and join us today for what is a remarkable day and an important event. I'd also like to thank the authors for their hard work and their exceptional set of papers that we have here today. The timing of this issue could not be better. What a difference 4 weeks can make. I am sure that for some, there is concern and anticipation. We are likely to experience a healthcare environment quite different than what we expected to face just a few weeks ago. So, are these papers still relevant? Absolutely. Not only are they relevant, they constitute the roadmap on how to move forward and how to manage the change that we should soon expect. For instance, in the first paper, Susan Jaffe introduces us to Evelyn Sell, a retired preschool teacher in need of dental care. Evelyn tells us every part of the body interacts with all other parts. If you lose a tooth, if you have a painful situation with your teeth, it's just as important as having a pain in your leg or fingers. There is often great wisdom among our patients. Evelyn understands something simple that we as a profession have struggled with for years. Evelyn got it right. As part of our struggle to make the case that oral health is health, we refer to studies, we contort conceptual models, and stretch biologic pathways. But why? Evelyn understands that dental care is important because it just is. Perhaps more important than finding a causal oral health systemic link is the very simple understanding that good oral health is intrinsically important. We know that dental pain can be debilitating. We know that dental infection can result in death. And we know that the early detection of oral cancer considerably improves the prospects for successful treatment. Indeed, Evelyn understands, and so should we. Jane Koppelman and colleagues provide a clue to the language, culture, and relationships that will be needed to advance oral health in a changing political climate. In their well-thought-out article on expanding where dental therapists can practice to increase access, they make the note of possible interest by new partners and free market advocates, such as Americans for Prosperity and Americans for Tax Reform. She notes that they support dental therapists as a market-based approach to address the problem of access because it promotes competition. Dr. Crall and colleagues in their important paper found that even in facilities that medical care and dental services are co-located, dental care is generally not integrated with medical care and often operates in isolation. In this paper, we learn that while substantial barriers to full integrative care remain, there also exists some low-hanging fruit for us to consider, target, and improve upon. Drs. O'Connell, Griffin, and colleagues in their two papers remind us that investments in prevention can result in net savings. We will find new partners to work with to help us advocate for those savings that we can show will result in long-term savings. However, in our advocacy, it's helpful for us to view and speak of savings in a more encompassing way. We should promote savings that are sometimes more difficult to monetize, including wages lost, work days missed, and school days missed. In the coming days and months, much attention will be paid to jobs and employability. We should be part of that discussion. And we have these articles to rely on. Dr. Chalmers and colleagues remind us that even with the best of intentions and expectations are sometimes confounded with unexpected and unintended consequences. Increased visits to the emergency department are problematic. But I caution our colleagues to remember that all emergency department dental-related visits are not monolithic. An emergency department can be an appropriate venue for a dental-related cellulitis, trauma, and other serious dental condition exacerbated by comorbid medical conditions. If oral health is health, we must agree that emergency departments visits are sometimes appropriate for dental care as it is for medical care. Finally, as we ponder what might be in the coming months and what might happen to the Affordable Care Act and all the gains that we have achieved for children's oral health, perhaps we might consider this an opportunity for a do-over. For all the gains we made, there have been lost opportunities as well. Too many adults and older adults were left behind. Perhaps a necessary compromise to achieve passage. A bill included child oral health care. It was a bill that left many of us wanting much, much more. We now get a second chance, another bite at the apple to do this right. We get a chance to work with new partners to promote new ideas. These new ideas will result in new gains with programmatic changes that will not leave anyone behind. With this health affairs issue in these articles, we have the foundation and roadmap to improve oral health and help us bridge the divide between oral health and health. Thank you.
Thank you, Rich. I want to follow up on a couple of the threads and just get a little bit of a conversation going. Beth, I was struck, you said that the quality issue was sort of your favorite, and it does seem to me that if we're interested in integration at a clinical level, we need to overcome some of the barriers you described in terms of data. My question would be, if you were to set forth an agenda of what needs to happen, not everything, but sort of the first thing, taking Rich's comment that it's time to think about how we can solve some old problems now. Where would we start in terms of changes that might enable the kind of research and delivery system analysis necessary to yield a more integrated approach to quality?
Yeah, so I think there's a couple pieces of good news, and that is that there are a number of groups that are working on quality metrics in dentistry right now, both using claims data as well as electronic health record data, and so that formative work is there. There is an increase in folks using electronic health records. However, what's missing, and there are actually now a set of diagnostic codes that are harmonized with SNODENT and the ICD, and I don't know, there's a long list of harmonizations, but I think that's been finalized. So the pieces that were missing to put that system together are now in place and exist. The next step is the leverage to have them be used. So if we have diagnostic codes, but nobody is forced to use them, meaning nobody is paid but for using them, then no one will use them because it's just extra work that we have to do. So the biggest barrier there is the lack of leverage that the public payers have, because without a Medicare leverage and with very limited Medicaid leverage, that really leaves most of the leverage to the private insurers. Many of them really are just sort of administratively administering these benefits as opposed to really managing a population. And so I think that's really where the question becomes, is how do we take these amazing tools that are now, that many people have spent years developing, and how do we get them into the delivery system so that we can then extract from the delivery system the information we need to improve it? Because we know the delivery system is not doing what it should be doing. 30% uninsured, huge disparities in oral health, #1 disease in children. This is not acceptable.
So Rich, you're in an academic institution. You're the chairman of Dental Public Health. It seems like that those words would indicate efforts to try to overcome some of these barriers. What do you see from an academic perspective?
Well, I like to think in terms of the process, not so much the what, more about the how. We've achieved so much over the last 20 years. And I think we need to start thinking about how do we approach the next 4 years, given the changes that we're going to see in Washington. How do we begin new conversations? How do we take the information that we have been advocating and the knowledge that we have and think about it in a different language, given a different culture, and how do we advocate for those things we want? Hopefully, some of that will be improved relationships between medical schools and dental schools, more integrated teaching, more integrated care. Dr. Crall in his paper did a wonderful job of talking about the difficulties of integrated care, even in environments where they're co-located. I think, though, that there are a number of the articles that we're going to get a chance to hear from today that did a really fine job of setting us up to begin those conversations and to better be able to have those conversations that will be required about how to move forward.
So let's take a specific example, one that's near and dear to my heart given my own background, which is the Medicaid program. Beth, as you mentioned, dental coverage is mandatory for kids. This would seem, from a financing perspective, like an opportunity for integration. You would think that we've eliminated one of the huge barriers that exists on the commercial side, certainly exists on the Medicare side. That's not the real world experience. So if we're in this world, Rich, as you describe, where people are sort of asking foundational questions, what's the next step? Given that at some level you would say we have the right platform, what change is necessary if we really want the integration that we claim is needed? Who wants to take that?
I'll take that first. That's fine. Thank you. That's a great question, and I appreciate that. You know, Medicaid is one of the things that's likely to change. We don't know what will happen, but there's a fair chance that at least part of Medicaid will be sent back to the states. If that happens, it's for us to begin the process of having the dialogue with each of those states and have the chance, you know, for 50 different experiments where we can actually try new policies, new procedures, and hopefully some of that will be what you described, actually integrating medical and dental. And, you know, payment is a powerful motivation to make that happen. That should be part of our conversation. Again, it's not so much what, because let the market work. Let's see what happens. But let us be the people who bring the information to the policy planners and the deciders about what the new opportunities are and what could be done and the value of integrated healthcare.
Yeah, and it is a great point. I think to follow up on that, I'm doing some work in Oregon, and prior to the Affordable Care Act, they actually moved to a coordinated care model that is sort of the entire program is capitated, and the care models actually, the coordinated care organizations actually manage both the medical and the dental. Now that hasn't led to a full clinical integration piece, but I think actually it's a wonderful model of the first step that you could take. It also positions that state very well if Medicaid does get block granted back, because they already have a system in place to accountable system to manage the what's going on there. So I do think that medical, that there's a financing piece right now. Even though Medicaid, there's a Medicaid program, the dental Medicaid is still fee for service, and in most states it's a separate organization than the medical Medicaid. And until you actually put those two together, and if you're going to go with a managed care capitated model, so that everybody is bearing the risk together. Right now you have these externalities where If you're a dentist and you don't do anything, nothing happens to you. Those kids end up in the ED, and somebody else pays for their care, and then the benefits of doing something doesn't come to the dentist. So if the dentist does treat the children or treats an adult, say, and that adult's diabetes is better managed, or that improves their cardiovascular health, or has other issues that leads to other better health issues, the dentist doesn't get that return on the investment. The healthcare system does. And so until we bundle those things together and really make people understand that there's a shared risk and accountability for the population health, we're just going to be turning our wheels again, because of those externalities are so great for the costs and the returns on where that money is getting paid, and ultimately patients are at the middle of it, and they're the ones who lose.
Beth makes a wonderful point. When we think back into the how Medicaid dental was structured, it was really well intended. On paper, Medicaid's incredibly generous. If someone were to hand me a Medicaid dental plan and say, this is yours, I would think it's wonderful. The problem is, with a large number of eligibles and with a limited budget, there's only one thing that can happen. With an enormous amount of procedures that are available, is you drive the price down on per procedures, and you basically drive providers out of the market. And look, it's not. I think we need to develop programs where we align the incentives to improve oral health, but yet still make sure that providers want to participate. So again, we may have the opportunity with a new administration to talk about new ideas about how to take all of these gains, all of the good work, all of the well-intended good work that we have accomplished in the past, and make it even better.
So I want to do two more topics before we finish. One is to round out this discussion. I'm reflecting on the experience of Medicaid with prescription drugs, where it's an optional benefit but covered in all states, and states like in the commercial sector would carve out drugs and hand them to a separate plan. And then there were all the concerns that you all have raised about dental, about it's not integrated, and so now there's an effort to pull it back in. But I'm struck by a theme that has come up, which is if we want to sort of hand broad financial risk, broad accountability, where is the management capacity for actually making the allocation decisions and care decisions that would be productive? If the existing dental insurance enterprise is really primarily claims paying and creating incentives for people to get preventive care, but not managing high costs, and certainly not managing across dental and medical. And if the medical plans are just not focused here, we can bundle all we want, we can make people accountable all we want, but without the data infrastructure, without someone who's doing this, where is this going to emerge? Who has the capacity to help redesign delivery, even if we make all the incentives just right?
Well, across the U.S., it's unlikely to happen in one fell swoop. And again, this may be one of the opportunities that we can look forward to. People respond to incentives, and organizations respond to incentives, and profit-seeking insurance companies respond to incentives. So I suspect that if the financial system were to be changed, we would get innovation out there in the marketplace that would come up with those kind of changes that we're hoping for.
Well, I think you're already seeing a transformation of the dental marketplace in very significant ways, in that, historically, similar to medicine back in the 1950s, dentistry, but for much longer than that, has really been small, independent, small solo offices with pretty much no oversight except for the dental board, and no real integration. Just, patients come in, they pay their services, they leave. And what we're seeing now is a huge growth in large dental groups, integrated dental plans, dental service organizations, dental accountable care organizations. They go by various different names, but essentially consolidation, where you go to an employee model or a contracting model where you have central management capacity. And we're seeing that is the growth area in the dental marketplace, and we're seeing the small offices really decline in terms of the overall share. So I think that when you add in the other pieces I was talking about before, plus this sort of movement towards larger consolidated organizational forms to manage those services, you're going to be able to see a better capacity to react to those types of incentives, because a single solo operator in the middle of America has no capacity to respond to the types of incentives that you're talking about. It has to be some sort of managerial, but we're already seeing that. So I think that would those types of incentives would actually probably increase that transfer, or speed up that transformation.
Great. Let me close with a completely different topic, which is around education, training. Beth, you offered a somewhat romantic view of the medical side and how much people learn in interprofessional settings. I know a lot of people who wouldn't characterize it quite thus, but you certainly indicated the divisions on the dental side. And we have a couple of papers, of course, on the topic, but I do wonder if either of you could reflect on the degree to which oral health in general is part of the interprofessional education movement. If we're trying to figure this out and build these kinds of systems, we need everyone who's touching the patient to have some degree of awareness and education across the parts of the body, if you will. So where is interprofessional education and dentistry?
Well, the CODA accreditation standards for dental education include experiences in interprofessional education. So it is part of the sort of educational mandate, so to speak. I think the way that it gets operationalized is very different, and it completely spans the gamut of maybe just in name only to some really amazing efforts to try to do integrative work. I think that one of the biggest challenges is translating that let's say you have an educational setting where you can really do a good interprofessional education. The problem is that when people go out into the marketplace and actually are working, there's no payment or incentive or structure to continue to support that. So it becomes an academic exercise that then doesn't not translate the way that we want it to into the real world. So I think we need to figure out a way to enhance that continuum and then have some feedback loops so that what's happening in the real world can then come back and actually inform how the educational enterprise takes up those interprofessional experiences to prepare people for that world.
And I believe it's already happening, maybe not at the pace we like. ADEA promotes interprofessional education and has done some great work with that. I know in our campus, our president has committed our campus to interprofessional education. Look, at some point, there will be a need for dentists to do more medicine. There will be a need for physicians to do what we consider to be oral health. There'll be a need for our nursing colleagues to do more of both. And how do we figure that out? It's going to take some time, but I think we're already on that path. I would agree that maybe a little slower than we like, but I think it's happening.
Well, look, if in healthcare, a little slower than we like is pretty typical. If we are seeing not just glimmers of hope, but also the potential for a discussion about how to spread the places where we find innovation and good practice, that's something to give us some encouragement and something to work toward. I want to thank you both for helping just get the stage set. I think it's a great platform for the rest of the discussion. So thanks to you, and I'm going to ask our next panel to come up. No break at this point, and we'll give you one after. But I'm going to come up here and get us started on round two. Any effort to divide up this topic into groupings is somewhat perilous. So we've taken our best at creating an outline for approaching the papers. The first panel focusing on cost, use, and access, and then we'll move into some of the public programs that have already come up, and we'll have a panel on the healthcare workforce. Obviously, use and access and workforce are related. cost, use, and access in public programs are related, but I think this collection of papers gives us a very nice starting point in addressing these topics. We'll hear from Marko Vujicic, Chief Economist and Vice President of the Health Policy Institute of the American Dental Association. Chad Meyerhoefer, Associate Professor of Economics at Lehigh University's College of Business and Economics, where he holds the Arthur F. Searing Professorship, and he's also a Research Associate at the National Bureau of Economic Research, NBER. We'll hear from Joan O'Connell, Associate Professor, Community and Behavioral Health at the Centers for American Indian and Alaska Native Health at the Colorado School of Public Health at the University of Colorado Anschutz Medical Campus. And Susan Griffin, Health Scientist in the Division of Oral Health, National Center for Chronic Disease Prevention and Health Promotion at the U.S. Centers for Disease Control and Prevention. So I will turn it over to start with Marko.
Good morning, everyone, and thank you, Alan. Let me just also give my congratulations to Alan and the Health Affairs team. Having worked in health policy most of my career, I recognize how big of a contribution this is to the evidence base for decision making, and it's not an easy task, and you've done a wonderful job of curating this. Let me tell you what the starting point was for this paper, which is joint with Tom Buckmuller at the University of Michigan and Rachel Klein, who I just saw is here, who was at Families USA at the time. We know that overwhelmingly, the top reason people say they don't access dental care is because of cost. All sorts of reasons. Too expensive, my coverage doesn't pay for it, etc. Far more frequent than any other factor, including fear, finding a provider. And we know this is robust across age groups, insurance coverage, etc. Let me just tell you briefly why we think that's actually mattering for society. And you heard the panel this morning talk about it, but let me throw out some rapid fire statistics as well. When people delay accessing dental care services, it has negative consequences economically, socially, emotionally. And this is something that we haven't had a lot of really good data on until the last 5 years or so, I would say. So for example, we know that emergency room visits for dental conditions have doubled over the past 10 years in the US. We know that 28% of young adults in America say that the condition of their mouth and teeth negatively affects their ability to interview for a job. Right? And we know that when people with chronic conditions don't have access to dental care, in certain segments of those populations, their healthcare costs go up. So avoiding dental care that you need is important, and that's our starting point. So let me just give you what we did. We looked at NHIS data, where people report whether they had to avoid certain healthcare services they needed due to cost. That's the variable we're going to look at. And the first thing we did is we compared how dental care stacks against other healthcare services. So this is a little hard to see, but there are two main conclusions here. One is when I look across age groups and compare children, adults, and seniors, I see that for all healthcare services, working age adults have the highest level of financial barriers. Next come seniors, and then the lowest level of financial barriers is for children. The second big takeaway here is dental care is an outlier compared to all other healthcare services. What does that mean? For all age groups, the likelihood of somebody facing financial barriers to dental care is much higher than for prescription drugs, primary care, eyeglasses, etc. So something happening here where dental care has the highest level of financial barriers for all healthcare services across all age groups. The next thing we did is we looked at only people with certain health and dental insurance coverage. And all I want to do is focus here on the left panel of this chart. So even when we isolate adults in this case, who have both private medical insurance and private dental insurance, which presumably means they have quote-unquote good coverage, you still see dental popping up as the service that's most likely to encounter financial barriers. So I guess our big takeaways there are obviously There's a coverage gap. You heard that this morning. Our next point was, well, why is this happening? Why is dental care seeing the highest level of financial barriers than other healthcare services? And there are two main factors we discussed. One is the coverage gap. So roughly about 1 out of 3 working age adults don't have any form of dental coverage, public or private. That's obviously much higher than for medical insurance. The ACA didn't do too much about that. But I think more importantly, and this is what surprised us somewhat, is the quality of dental coverage seems to be lacking. Why is it that with private dental insurance, you're still seeing dental care having much more likelihood of seeing financial barriers? So it's not just an issue of, well, let's fix the coverage gap and everything will be great. These data suggested strongly to us that, wait a minute, there may be something fundamentally weak about the private dental insurance model. And that's where we get to the where do we go from here. And our big takeaway was we feel there are 2 major areas of action that policymakers need to consider. And the one big one that has to go first, in our view, is fundamentally redesigning the nature of dental benefits and dental insurance, right? So that it actually pays for the attainment of oral health outcomes rather than for menus of procedures with dollar limits and coinsurance rate that, in our view, may have been well thought out 30 years ago, but today are not. We should not be seeing this level of financial barriers with individuals that have coverage. Fundamentally, insurance is meant to protect you from financial barriers and risk. And we feel on the dental side, the model is very outdated and needs some rethinking. So what does that mean? We can talk more about it later, but concepts like paying for outcomes. And we now have some new measures we didn't have 5 years ago to measure that. How do I measure whether I improved your oral health, right? Incorporation of risk. And then finally, the second part is once we make those improvements, expanding coverage. So you heard the debate about, well, Medicaid, dental care for adults is an optional benefit. Medicare does not cover routine dental costs. Within the insurance marketplaces so far, we haven't had a lot of embedding of dental coverage within medical plans. I certainly think there are some interesting experiments, like in Covered California, where they've gone full steam to embed dental coverage within medical plans. So we discussed that in the paper about what are some of the risks and benefits of doing these coverage expansions. We've also highlighted costs to do this, at least in Medicaid. And so I'll stop there, and thank you.
Thank you, Mark.
Well, I want to thank Alan and the Health Affairs team for organizing this event and giving me the opportunity to speak. And I also want to thank my co-authors on this work, which are Irena Panoska at Lehigh and Rich Manski at University of Maryland. So the objective of this study was to project rates of dental care use and dental visits 10 years into the future, and also to account for the impact of the ACA on those 2 outcomes. So there's 2 main ways that the ACA impacts dental care use, and these have been mentioned already by some of the speakers. One is that Medicaid is now required to offer dental care coverage for children as an essential health benefit, and that was largely the case through the SCHIP program prior to the ACA. But Medicaid has also expanded to a larger proportion of the low-income population, and there are about 25 states that extend dental benefits to adults in some form that expanded their Medicaid programs. The other main avenue is through private insurance sold in the health insurance exchanges, and then indirectly through employer and individual mandates to purchase private insurance. So plans sold in the exchanges need to require pediatric dental coverage as an essential health benefit, although parents are not legally obligated to take that coverage up. So in this study, we used data from the Medical Expenditure Panel Survey from 1996 to 2013 to estimate the model. And the first thing we did was we projected rates of use and total visits up to present day, so 2017, which we'll be getting to pretty shortly. We then made a further projection out to 2026 that's based just on the historical trends and institutional structure of medical and dental insurance that we've had in the past. So that projection would also be the one that's relevant if provisions of the ACA that impact dental care were repealed. And then we incorporate the impact of the ACA in 2 stages. And these 2 stages are the rightmost columns in the table. So the first one is that we account for the expansion of Medicaid and the increased access to private medical insurance through the health insurance exchanges. That's the 3rd column in the table. And in the last column, we make the strong assumption that all children who are offered private dental insurance take that coverage up. So that is really provides an upper bound on what the impact of the ACA could be, because parents are not obligated to take that coverage up. But if all of them did, this would be the impact on rates of use. So overall, what we find is that there's a 4 percentage point increase in rates of use due to all these factors, and an increase in dental visits of about 31 million visits per year. Now, about half of that in each case is due to the ACA, and the other half is just due to other trends related to increases in income and education and other factors. So overall, the ACA is increasing rates of use and increasing visits by about 5% relative to what the historical counterfactual projection would be. Now, to put this into historical context, I wanted to show you just the forecast for total dental visits that go all the way back to 1996. So you can see that total dental visits have been increasing. Much of this is driven by more visits among children. So the blue line there is the historical projection. The red line is the impact of the Medicaid expansion and the expansion of private insurance through the health insurance exchanges. And then the green line adds on the assumption that all children take up private dental insurance who are offered it. So, the gap between the blue line and the green line is 17 million visits per year in 2026. The dotted lines there are confidence intervals around these estimates. Now, we also looked at different types of dental care. So in this chart, what I'm showing you are projections based on the expansion of Medicaid and private insurance, but these don't make the stronger assumption of full child take-up. The top line there is preventive services, so services for preventive dental care. The red line is dental treatment, and then the green line is visits where both preventive care and treatment were rendered. So there are some long-standing trends in the industry. The demand for preventive services is increasing, and it's continuing to do so under the ACA, whereas the demand for dental treatment, is declining. Now, these trends have implications for costs and for the structure of the dental workforce. So a larger proportion of services will fall under the scope of practice of dental hygienists in the future, and that could help to alleviate shortages in the supply of dentists due to retirement of the baby boomers. Now, because preventive care is less expensive than treatment, these trends, along with other factors, help to reduce dental care costs. So by our estimates, there's about a 20% reduction in dental expenditures by 2026 because of these trends and other factors. And lastly, I just wanted to show you what differential rates of use look like between children and adults. Now, in this case, we don't adjust for the ACA. These are based on historical trends because our data source for those adjustments wasn't broken out separately between children and adults. But the graph makes pretty clear that since 1998, rates of dental care use among children have surpassed adults and increased at a much higher rate than for adults. This is primarily due to the availability of dental insurance through the Medicaid program and other factors. Now, in the future, we do see the decline in dental use among adults flattening and increasing just a little bit, but there's quite a large gap there. And I think there's several ways that gap could be closed because the proportion of the population that's elderly will be increasing in the future. One of the more effective mechanisms would probably be adding a dental benefit to the Medicare program. but also expanding coverage in the Medicaid programs to adults in states that don't do that already would also help close this gap. Thank you.
Thank you.
Good morning. I'd like to thank Health Affairs for the opportunity to present our findings on costs and savings associated with community water fluoridation programs on behalf of my co-authors, Jenny Rockel, Judith Willett, Scott Tomar, and Bill Mass, who's here in the audience. For 70 years, fluoride has been added to community water systems, and almost all water contains some naturally occurring fluoride, however, not enough to prevent tooth decay. Water fluoridation is the process of adding small amounts of fluoride to community water systems to make teeth stronger and prevent caries. In 1999, the CDC recognized community water fluoridation as one of 10 public health achievements of the 20th century due to the association between its effectiveness and the costs of providing fluoride. The Community Preventive Services Task Force reaffirmed its support for fluoridation in 2013. Despite this, 26% of the population that's served by community water fluoridations do not have fluoridated water. In addition, each year, communities that have fluoridation have ballot initiatives, votes in city councils, and through other decision-making processes, make decisions about continuing to fluoridate their water. Our goal of this study was to provide updated information on the costs of water fluoridation and treatment savings to inform decisions about continuing or implementing water fluoridation. In 2001, the Centers for Disease Control and Prevention published the most comprehensive U.S. study on this issue. We developed an economic model to build on those findings using updated information on the costs of fluoridation, updated information on caries increments, that is the onset of dental caries each year, and treatments for dental caries. We employed an economic model called the Markov model to include data that we analyzed, information we obtained from public data sources, and expert opinion, using 2013 as the base year for our model results. So I'll briefly describe our methods. We obtained data from the CDC water fluoridation reporting system to describe who lived in communities with fluoridation. Approximately 211 million persons, or 74% of people in the United States with access to community water systems, have fluoridated water. Over half the persons with water fluoridation, 55.1%, lived in communities where water systems served 100,000 or more persons. As you can see from the slide, the cost of fluoridation in those communities averaged 43 cents per person per year. Approximately 20% of the population with fluoridated water lived in smaller communities with water systems that served 20,000 or fewer persons. And due to economies of scale, costs were higher in those smaller communities. Using these data, we were able to estimate the annual costs of providing fluoridated water in the United States. So how did we estimate savings? We started by using 3 waves of the National Health and Nutrition Examination Survey to estimate the onset of caries during each year. As you can see from this slide, caries increments vary by age for primary teeth and for adult teeth, both looking at coronal caries and root caries. In our model, we assumed that community water fluoridation programs reduce the onset of caries by 25% during a year. We obtained this estimate from the Center for Disease Control, and it was based on the review of many studies. With information on the age of the U.S. population, we were then able to estimate the number of caries averted due to water fluoridation during 1 year for the population with fluoridated water. Savings were estimated as the costs associated with dental treatments that were averted due to reductions in caries. We assumed that all prevented caries would have been treated, and those treatments would be similar to treatments obtained by persons with private health insurance. We analyzed data from 3 insurers who covered persons located throughout the United States. We do recognize that not everybody has private coverage, and that treatment patterns vary by type of coverage and person's income. However, for a number of reasons, we decided that private dental treatment patterns reflected treatment practice standards and consumer expectations about the benefits of maintaining a tooth over the lifetime, for many of the reasons discussed earlier and by the earlier panel members, related to health of the teeth, general health, missed days of work and school, etc. In addition to accounting for the costs of initial treatments that may have occurred in our base year, 2013, we accounted for replacement treatments or restorations over a lifetime for accounting for the value of maintaining a tooth. We used age as a proxy to decide what types of treatment a person might receive for their initial and follow-up treatments. For example, we assumed initial treatments would be similar to youth ages 16 to 18. Finally, we found that for every dollar saved, invested in water fluoridation, $20 were saved. Of course, savings can vary by communities because the cost of water fluoridation varies by communities. However, our savings estimate of $30 per capita could be used to compare savings to the cost of a specific community. There's 3 other points I'd like to mention. First, I'd like to mention that once fluoridation is implemented in a water system, there's no cost for consuming fluoride. Thus, water fluoridation is a great way to prevent or reduce oral health disparities. And finally, I think it would be beneficial if there were increased opportunities to educate the public about the benefits and costs of water fluoridation, so that as communities make decisions about this, they're better informed about those issues. Thank you.
I have night blindness, so that's why I'm leaving. Okay, thank you. It's a pleasure to be with you this morning. The other authors on this study were Paul Griffin, Christina Scher, and then from CDC, Sajal Chattopadhyay, Shilpa Naval, and Kate Harris. So first, some background. And dental sealants prevent about 80% of cavities after 2 years in the back molars, where about 90% of cavities occur. Poor children are about 20% less likely to have dental sealants. And why this is problematic is poor children are also twice as likely to have untreated tooth decay. So school sealant programs are an effective strategy to increase sealant prevalence among low-income children. And school sealant programs typically target schools where you have a large number of children on the free and reduced meal program, and they deliver services at little or no charge to students. So in our study, we looked at the net cost per averted disability-adjusted life year from a school sealant program sealing all 4 permanent first molars soon after they erupt. And this is typically between ages 6 and 7. And we use disability-adjusted life years as our outcome measure because in dental, it's typically you don't use an outcome measure that is comparable to those used for medical interventions. So we wanted to be able to directly compare our findings. And then secondly, as has been pointed out, there's, untreated decay can impose a large burden on a child's quality of life. And it's, these programs serve kids who are underserved. So it's likely that but for the sealant program, the decay that occurred would have remained untreated. So we used two thresholds for economic viability. The first was it cost saving, and the second was it cost effective. And for cost effectiveness, we used a threshold of was net cost per averted daily less than U.S. GDP. And in the next few slides, you're going to see that all of the dollars are presented at 2014 dollars. So U.S. GDP per capita in 2014 was about 54,600. Okay. Oh, okay, thanks. Which one is this? Okay. On the right side. Okay. There's one in every panel. Sorry. Our base case findings were school sealant programs for cost saving. So if we were to seal 1,000 children, then we would save society roughly $8,500, prevent 133 children from living with the year of toothaches, and prevent about 1.6 DALYs. In our base case analysis, we used a time span of 4 years. There is some evidence that sealants can be effective up to 9 years. So we expanded the time horizon from 4 to 9 years. Cost savings was tripled, and the averted outcomes increased by about 30%. When we excluded productivity losses, school sealant programs were still cost saving. We also looked at worst case scenarios, and again, school sealant programs remained cost effective. So, for example, if a program were only able to seal 3 teeth, or as been pointed out, Medicaid reimbursements are much lower than private dental reimbursements. For fillings, they're about half as much. So, which is a better representative of societal cost of resources to provide the filling, Medicaid billings or what private insurance would reimburse? And so, when we used the Medicaid, which is quite low, again, it remained cost effective. So in this next slide, we allowed the parameters to vary between 50% below and above their baseline value to see which parameters have the largest impact on cost effectiveness. And so you see that the parameters with the widest horizontal bar are going to be those that are most influential. So the three parameters were the child's underlying caries risk, or the probability that a tooth would develop, a sound unsealed first molar would develop a cavity within a year. The second would be the restoration cost, and the last would be school sealant program cost. So we next allowed school sealant program cost and underlying caries risk to vary simultaneous to look at what happened to economic viability. We chose these two factors to vary because, first of all, they're two of the most influential, and second, they're factors over which a school sealant program is likely to have some control. And so the areas in yellow are cost saving, the yellows in orange are cost effective. So for example, if you look at for school sealant programs cost less than or equal to $60, if the annual probability of developing a cavity is less than 0.07, they're cost saving. Now, to provide some context, what does a probability of 0.07 mean? In our study, we used data from about 40,000 kids that were screened by school sealant programs at baseline, and in 14 states funded by CDC, and we estimated this value to be 0.078. If you use the same methodology on national data from 2011 to 2014, it's similar, but a tad lower at 0.072. So given that, it looks like school sealant programs are cost-effective under a wide range of scenarios, finally, we looked in the paper at some strategies that could be used to increase school sealant program coverage. And the first would be to provide a steady stream of financing. Typically, federal funding of school sealant programs is done through competitive grants. So when the funding period is over, the funding can dry up. It's possible for school sealant programs to be able to generate enough funding in Medicaid billings that if their costs are sufficiently low, they might be sustainable. And we have a couple of states where this is actually the model that they use. And So labor accounts for about 2/3 of the cost of a school sealant program. So state policies that dictate having to use a higher cost unit of labor can have a large impact on school sealant program sustainability. And so, for example, one study found that state policies that require a dentist to be present to assess whether a child needs sealants, as opposed to letting a dental hygienist do this function, can increase a sealant program cost by between 20 to 30%, depending on program size. So, in conclusion, school sealant programs appear to be, a good investment under a wide range of assumptions. However, at the community level, what the optimal portfolio of prevention strategies is going to be depends on local conditions. And so we hope that in this analysis we provided decision makers with some useful information to determine if school sealant programs are attractive relative to the competing interventions. Thanks so much.
Thank you. I'm going to direct one question to each of our presenters before we open it up to you all to ask your questions. Marko, I just want to note, as you were presenting your data on the second exhibit, you focused on the left panel, people with insurance. I was looking over at the right panel, people without either medical or dental, and noticing that the cost barriers are higher even for dental, even for those with neither type of coverage. When I think about the share of the economy, I think about the costs associated with medical care, that finding also stands out. I just wondered if you could reflect on why that is true as well as the left side of the chart.
So a couple of hypotheses. I mean, one could be, and I'm not saying it is, that access to kind of charity care or safety net facilities may be easier on the medical side than on the dental side for the uninsured. There's a paper later that Jim will kind of shed some light on that. It could also be that just people's willingness to pay. I mean, these types of self-reported data, they incorporate subjectivity. Right? So if I have a pressing medical issue, I may view that as a higher priority than a pressing dental issue, and therefore, even at the same price, I may report less of a financial barrier. So that's one of the limitations, but it's a good question. It's for another paper.
We will look forward to that paper. Chad, from an oral health perspective, those diverging lines, as you noted, translating to 17 million visits per year. It's a big effect. From a sort of health systems perspective, thinking about the scale of change in the Affordable Care Act and the amount of unmet need, which is documented in many places, seems like there's still a long way to go. So I wonder if you could reflect on sort of what the going back to Rich's opening comments this morning, if we were to do a do-over, or at least conceptually think about an alternative way to do this, if we were trying to close the gap between where we are and where we really want to be, what kind of policy variables might really make that slope much higher than it is?
Right. So there is a big gap because the ACA just intrinsically wasn't designed to address dental care usage to the extent, anywhere near the extent of medical care. And then there's some just demographic trends that are pushing dental visits up, like increases in education, increases in income, and those are as powerful as the reforms that are part of the ACA. One of the things that I mentioned, which I think is key, is just the demographic transition to a higher proportion of elderly in the U.S. And so, adding the dental benefit to the Medicare program would seem to be, the easiest and most probably cost-effective way to bridge that divide between adults and children. Only about 12% of children don't have access to dental care right now, or dental insurance, rather. And so there's, because of the progress we've made in that regard, there's just a limited amount that visits could increase, or rates of use could increase without really instituting major reforms for the adult population.
Thank you. Joan and Susan, I want to ask a pair of questions for both of you both of you presenting cost effectiveness results. And these are a bit impertinent, forgive me, but I just want to get a conversation going. The first is the degree to which cost effectiveness analysis actually matters in the decisions that we make. Joan, you obviously referred to hesitancy around fluoridation, which is well known, but I assume there are also institutional barriers to sealant programs, and I just think it would be interesting to put these findings in context so that we know how they can be used. But I'm also methodologically interested in the question, Susan, which you addressed directly in your presentation, which is given low reimbursement that also yields low utilization. When we do these analysis, we in some sense bake in existing inadequacies of the system. And if you were to ask conceptually what's the effectiveness, you might get a different answer than what you get when you add up the numbers of existing dollars in a suboptimal system. So I know those are two really small questions, but I just wonder if the two of you could offer some reflections on either one of those if they grab your fancy.
Well, I guess, is this on? Okay. I guess sealants may be the low-hanging fruit in terms of does the modeling match the data, in that there have been analysis of claims, Medicaid claims data, and there have been 3 analyses, and one found that school sealant programs were unequivocally cost-saving. Another found that they were only cost-saving when they were delivered to high-risk children, and then the other found that they were rarely cost-saving. But you talk about baked in. When you look at Medicaid billings, the sealant rate is much closer to the market rate than the filling rate is. So you are automatically biasing it somewhat towards finding that they're not cost-saving. But I guess the second thing is we are approached by decision makers at CDC, and we're asked to give them estimates of what the cost-benefit or benefit-cost ratio would be. And it's interesting how all of them on a payback period, within 4 years. But decision makers do ask for this information, so I'm assuming that it's useful to them. So.
Joan?
Great. Well, we tried to address the value of maintaining a tooth over time by assuming that people would have dental treatment similar to an insured population with money to afford the care. And we know that's not the case, but we felt it reflected a lot of the concerns people mentioned earlier today, that untreated dental caries are associated with a number of oral health conditions, tooth pain, that can lead to missed days of work and school. We know it has effects on other health conditions like diabetes and heart disease, low birth weight. And we also know it affects people's nutrition as teeth are extracted. And so we attempted to estimate the value of all these things that are well recognized but not well quantified in dollars in our study by assuming that treatment patterns would reflect those of people with coverage and money. And I think more research is needed to better put values on those issues. We know how wonderful it is when you walk into a room and people smile at you. And we know that, as you mentioned earlier, people have concerns when they interview for jobs due to their oral health.
Very good. We have time for audience questions. We have microphones and we're videotaping this, so we do need you to wait for a mic. There's a question in the back, and please identify yourself as you speak.
Hi, I'm Jane Tilley with the Administration for Community Living, and I'm wondering if there have been some cost estimates done around oral health, the relationship of treating oral health conditions for people with diabetes, cardiovascular disease, in some of these chronic conditions where there's well-established links between poor oral health and poor cardiovascular and diabetes, and vice versa. Thank you.
Margaret.
There was an analysis that was in the American Journal of Preventive Medicine, which is a systematic review of the cost effectiveness of what happens to treating dental conditions on the overall cost of chronic conditions. Diabetes was one, and I believe heart disease was one. And as soon as the next speaker comes up, the name of the author will come to me. But if you'll come to me afterwards, it'll come to me in a minute.
Okay.
Yeah. So yeah, the couple of papers that look at this, and most of it deals with gum disease. It's Marjorie Jeffcoat that wrote that paper, and my group also had a paper in health economics. Well, big picture, there is something there. So even when you net out the cost of dental treatment, there is still a net savings in medical care costs, especially among diabetics, but among people with cardiovascular disease and some other conditions. The dollars is where the arguments are. Our analysis was on the low side of the published estimates, to the tune of about $800 per year saved in medical costs among newly diagnosed diabetics who have access to dental care. The earlier paper you were mentioning, Susan, it's in the thousands. Yeah? So there is something there as a health economist to me that passes the sniff test. There are positive savings. The dollar ranges we're still having pretty wild differences.
Yes, sir, right in the middle.
Maybe I can squeeze
Can
in
you
two questions.
introduce yourself, please?
I'm Steve Corbin, and I used to be in dentistry, and now I'm just a citizen playing golf and cooking dinner for my wife. The opening session where you set the stage, you and Dr. Manski, question I have is that while everybody in here may be all aboard with integrated care and all that, what's the real demand for integrated care amongst the predominant provider group, dentists, hygienists, and all that? Because I think there is maybe more of a cultural and political issue there than there is a basic science, clinical, medical issue. And my second question, totally different, more to this panel, is thought about looking at lifetime costs of health care for a model person or several models that includes or doesn't include oral health care. Because I think dentistry is actually getting cheaper. This is my intuition over the several decades relative to the rampaging costs of medical care and surgical care and pharmaceuticals and organ transplants and management of long-term chronic diseases like cancer. So it may be that dentistry's, being that add-on benefit conceptually, is coming at a lower relative cost than maybe any time in history. And modeling lifetime costs of care may be a more practical way to talk to policymakers and the public about, hey, care is expensive. Let's get that off. Care is expensive. Maintaining health is expensive.
So I'm going to suggest that you all focus on the second question. We'll do the first one at the break. But the second question really is, as all of you bring in these issues of cost, do you have a sense of, from a historical perspective, are we on a different trajectory than we have been in the past, different trajectory from medical that would have potentially quite significant implications for all of your work? Whoever's, yes, Jen.
Yeah, so when you say dental care is getting less expensive, it's complicated because, expenditures are going down, but that's mostly because of the source of payment. So there's a higher proportion of payments from the Medicaid program, and those payments are lower. So when you look at aggregate estimates that show the cost decreasing, that's basically what you're seeing. If you were just to look at the cost of privately provided insurance and how much they're paying relative to private medical insurance, I'm not sure there'd be such a big difference. So that's part of it. But there are some things that are suggesting that long-term costs will be lower, and that's just the fact that you have a cohort of individuals that has had exposure to fluoride, that's wealthier and better educated entering their later years. And although they're going to demand more dental services, they've had more preventive care, and that's going to lower long-term costs. And just the fact that we're doing a better job of providing preventive care will lower costs because those visits are cheaper and they basically, they prevent more expensive treatment later. So overall, you're correct, I think, about the long-term costs going down, but it's maybe not as dramatic as like an average number would suggest.
I'm going to stop us here. You all were very quiet after each presentation, but please join me in thanking all of these panelists. We are going to take a 10-minute break. I'd like to keep it to 10 so we give our excellent papers coming up after the break time. And please help yourself, as noted earlier, to the food in the back. Thank you. This next set of papers focuses on public program coverage. You've already heard reference to both provisions in Medicaid, where children are covered and parents are optional, and of course in Medicare, where dental coverage is quite limited. We have 4 papers on the topic. We'll hear first from Amber Willink, Assistant Scientist of Health Policy and Management and Assistant Director of the Roger C. Lippitt Center for Integrated Healthcare at the Johns Hopkins Bloomberg School of Public Health. We'll hear from Brandy Lipton, a health economist at the Agency for Healthcare Research and Quality as part of the United States Department of Health and Human Services. Jaffer Shariff is a research analyst in the section of population oral health at the Columbia University College of Dental Medicine and a periodontal resident at the school. And Natalia Chalmers is Director of Analytics and Publication at the DentaQuest Institute. So I will turn it over first to Amber.
Good morning, everyone, and thank you to Health Affairs for having us. I agree this is a very important platform to be having this conversation. So, with that, as was previously mentioned, Medicare does not cover dental services unless it's an integral part of another covered service. So, for example, if someone has a terrible injury and they need their jaw reconstructed, then Medicare will provide some financial assistance, but otherwise it's not a covered service. And yet there is substantial oral health issues among older adults. So we see 1 in 5 older adults have complete tooth loss, and another 20% have untreated tooth decay. So with this substantial oral health issue, though, we only see that 12% of Medicare beneficiaries report having some type of supplemental dental coverage. And this was from the Medicare Current Beneficiary Survey 2012. So in our paper, we talk about some of the access issues, we also talk about the cost burdens, and then we put forward 2 different policy options by which Medicare could offer dental benefits. And so firstly, we look at the access issues, and the red bar is showing those who did not report having any dental insurance. And what we see here is a really steep relationship between income and accessing or having a dental visit in the past 12 months. And among those in the blue line with dental insurance, you see that this relationship with income is largely diminished once they do have insurance. We do see a lot more people, once they do have dental insurance across all incomes, having at least 1 dental visit a year. When we look at the cost burdens, we see that Medicare beneficiaries on average spend $427 a year on dental services, 75% of which is spent out of pocket. When we're looking at the near poor Medicare beneficiaries, so those are below 200% of the federal poverty level, which is about $25,000 a year, and that are not covered by the Medicaid program, 10% of their total out-of-pocket spending is going to dental services every year. When we're comparing between those without insurance and those with insurance, the average out-of-pocket spending is really quite similar. So it's $319 a year for those that did not report having dental insurance, and about $410 among those who did have insurance. And yet when we look at their total spending, it's almost double among those that did have insurance. So we're seeing almost the same or similar out-of-pocket expenditures between the 2 groups, but double the dollar value in services for those who do have insurance. And so this brings us to our policy options. What we did was we constructed a benefit that was similar to private plans that were on the market. So it was covering 1 preventive visit in full a year, which was cleaning and an exam, and then spending, a cost sharing of 50% for necessary care up until a total spending limit of $1,500 a year. And so with that benefit, we looked at financing it in 2 different ways. The first way is very similar to the Part D prescription drug plan. And we did this because it's an example of a previously non-covered service under Medicare that became a covered service. So this is a successful example of how that's possible. So we did that first, and then the second was what is often put forward and has been previously put forward in Congress, which is including a dental benefit as a core part of the Medicare program. When we costed out the first option, it's voluntary, it's a supplemental plan, and it's fully premium financed. So that would be $29 a month for beneficiaries. For both of these options, we included a low-income sliding scale subsidy. And this is in the same way as is done for the Part D prescription drug plan. And this is important, as we saw before with some of these access issues, that particularly among the low-income groups, we need to provide some additional financial support so that purchasing a dental benefit in this situation would be possible for them. So the low-income sliding scale subsidy would be $4.4 billion a year for the federal government. In the second option, where we included as a core benefit, which means everyone would have access to dental services with this benefit, would be and 25% premium financed, which is about $7 a month for beneficiaries, and 75% general revenue, which comes to $14.7 billion a year for the federal government. The additional low-income sliding scale subsidy is $3 billion a year. And just to clarify again, with the low-income sliding scale subsidy, that's for people to 150% of the federal poverty line. And it's sliding, so it's no one pays a premium below 135%, and then it's sliding scale from the 135% up until 150% of the federal poverty level. So in our paper, we put these two options forward, and we don't advocate for one or the other. This is simply informing the conversation as we move forward with this idea of how you could potentially cost out or propose a dental benefit under Medicare. So I'd like to acknowledge my co-authors, Karen Davis from Johns Hopkins and Kathy Shane from the New York Academy of Medicine, as well as the Commonwealth Fund that made this funding possible. Thank you very much.
Thank you so much for having me here today. Today I'm going to be talking about our study where we seek to examine whether gaining access to public health insurance eligibility could possibly have lasting effects on oral health. And I want to acknowledge my co-authors, Laura Wary at UCLA, Sarah Miller at University of Michigan, Jenny Kenny at the Urban Institute, and Sandra Decker at the Agency for Healthcare Research and Quality. Just a very quick disclaimer, the views expressed today are my own and they don't represent the views of AHRQ or the Urban Institute. So to give you some background for our study, prior to the 1980s, Medicaid eligibility was tied to receipt of cash welfare through the Aid to Families with Dependent Children program. But during the 1980s and 1990s, a series of congressional acts led to a very large expansion in Medicaid eligibility among pregnant women and infants. And this figure is illustrating that. So this shows the percentage of 15 to 44-year-old women who would have been eligible for Medicaid in the event of a pregnancy by the year of birth of the child between 1979 and 1991. And this is shown by racial ethnic group. So as you can see, the percentage of women eligible for pregnancy or infant-related Medicaid coverage increased substantially over this period for all racial ethnic groups, though the largest absolute increases were among non-Hispanic Blacks and Hispanics. So among non-Hispanic Blacks, for example, this percentage increased from about 32% of women to 60% of women. That's a 28 percentage point increase. So there were many studies that sought to examine the concurrent effects of these expansions on a variety of outcomes. And there's now an emerging literature that's exploring whether these expansions may have had long-lasting effects on health and other outcomes. So to give you a sense of what some of these studies are finding, researchers have found that young adults who are more likely to benefit from these eligibility expansions have reduced mortality, reduced emergency department visits, increased educational attainment, and improved socioeconomic status, among other things. And kind of the idea behind all of these studies is to use a measure of public health insurance eligibility that allows the researcher to isolate the effects of changing the state level rules governing eligibility separate from other potential factors such as changing demographic characteristic composition at the state level. And the way that they do this is they attempt to use differences in the timing of expanded coverage by state and by year of birth to try to disentangle these effects. So in our study, we wanted to look at whether these expansions may have had an effect on oral health that lasted into young adulthood, and we're going to use a very similar methodology to these prior studies. And we think that these expansions could have had an effect on oral health for a variety of reasons. So first of all, these expansions may have increased access to care and therefore possibly improved health, both oral health and general health among expectant mothers. And we know that there's a link between the health of the mother and the infant slash child. We know, for example, particularly with respect to oral health, that karyogenic bacteria, which is the main cause of dental caries, can actually be passed from mother to child. So that's one potential mechanism. In addition, since the coverage, the eligibility expansion was linked to the child up to age 1, if the pregnant mother became eligible, then there could have been increased access to care among infants, and maybe even more importantly, among mothers. They may have gained additional education into how to best care for their children, both oral health care and other care. And then finally, during our period of study, in addition to increases in Medicaid eligibility for pregnant women and infants, there was also a substantial expansion in eligibility among older children, both through additional Medicaid expansions and also through the introduction of the Children's Health Insurance Program in 1997. So that's something that we're going to look at as well in our analysis. We're going to look at both these eligibility expansions to pregnant women and infants, and also to older children at ages 1 to 6 and ages 7 to 18. And we were particularly interested in looking at this question by race ethnicity. And the reasons are, as you saw in the last slide, the effects of these public health insurance expansions we studied did differ by race ethnicity. There were larger absolute increases among racial ethnic minorities in eligibility. And also because we know that oral health problems are more prevalent among racial and ethnic minorities. In particular, racial and ethnic minorities are about twice as likely to have untreated tooth decay by ages 2 to 5 compared to non-Hispanic whites. So for our analysis, we used our main data sources, the Behavioral Risk Factor Surveillance Survey between survey years 1999 to 2010. We're going to look at a sample of young adults, ages 19 to 31 at the time of the survey, which means that they were born between 1979 and 1991, which, as you saw in that previous slide, those people were subject to these very large expansions in public health insurance eligibility. So what we did in our study was we linked measures of public health insurance eligibility for pregnant women and infants, and then also for children at ages 1 to 6 and ages 7 to 18 that we computed using the current population survey to these young adult respondents in the behavioral risk factor surveillance system to attempt to see whether these measures would be associated with oral health outcomes in the BRFSS. And in particular, we looked at reported tooth loss. So we used a regression-based analysis to try to look at this question, and we controlled for a variety of demographic and state-level factors in our analysis to try to really look at whether eligibility was associated with tooth loss outcomes in young adulthood. And to give you a sense of the results, we found that a 10 percentage point increase in Medicaid eligibility at the time that the child would have been in utero or during the first year of life was associated with about a 3 percentage point reduction in the likelihood of having any tooth loss as a young adult. And this was about a 14% reduction relative to the average in the sample of having any missing teeth. We didn't find any evidence of a lasting reduction among non-Hispanic whites or Hispanics, only among non-Hispanic blacks. Though we did find some evidence that expanded public health insurance eligibility at ages 1 to 6 was associated with a reduction in tooth loss among not only non-Hispanic blacks, but also among Hispanics. So based on our study results, we know that Medicaid eligibility among non-Hispanic black pregnant women and infants increased by nearly 28 percentage points between the year of birth, 1979 and 1991. And so kind of interpreting our results in a different way, our results suggest that the observed gap in tooth loss among young adults who are non-Hispanic black and non-Hispanic white would be approximately 80% larger today if there were not those Medicaid expansions in the 1980s and 1990s. And we think that this question deserves more attention because our results and the results of many other studies suggest that the effects of expanding public health insurance can actually persist well into the future. So we think that there's a lot more work to be done in looking into a variety of effects, including oral health. Thank you very much.
Hi, good morning, everyone. I would like to thank the Health Affairs and the Health Affairs team for giving me this opportunity to present our study. I would like to especially thank Laura Norris from CMS, who's here for her input during our paper. So basically, our study talks about Medicaid if it meets its equal access requirement for dental care, but does disparities remain? Now, my mentor and my boss, Dr. Bertel Edelstein, couldn't be here, but he sends his regards. He is the policy person who I work with, and he's the mind behind all this. So what do we already know? From the previous researchers that have been published on insurance, we know that the insurance coverage for pediatrics especially has been raised from 70% from 1996 over to 86% in the year 2013. Public dental coverage, especially the Medicaid, has steadily increased over the years amongst the children. Private insurance, while has moderately declined. Now, how does that affect the utilization of dental care? Now, the previous panel did talk about utilization. You see that utilization of dental care has increased over the years. And especially if you look at the Marko Vujicic paper, you see that from 24% to in 2005, it's increased, the gap between the rate between private and public insurance has reduced from 24 to 15% in 2016. Other papers also talk about the initiatives that have been taken by CMS to increase the utilization care. So despite the significant increase in utilization that we see across the board since 1996, that has been increased after the implication of Medicaid, and with the expansion in 2009, and even the incorporation in the ACA, or the Affordable Care Act, certain disparities remain. So what did we want to know by this? We wanted to see if Medicaid was meeting its equal access care provision. We also wanted to see, does equal access to care mean good oral health status? What is the outcome? So what did we do? So we used a data set. Our data source was the National Survey of Children's Health for the year 2011 and 12. This is it's funded by the Maternal and Child Health Department. This is by the U.S. Department of Health and Human Services. This is the population of interest was basically children and adolescents between the ages of 1 to 17. They incorporated from every state about 95,000 individuals. Now, our dependent variable, the variables that we were interested in looking was first use of dental care, the use of dental care. Now, we used two questions for this. We used, that was part of the survey. We used preventive dental care utilization in the last 12 months and any dental care in the last 12 months. Also, we wanted to look at the oral health indicators. We had three. One was, how did the parents report their teeth's the teeth's condition? Was it excellent or very good? Did they have any dental problems in the last 12 months? Do they have any dental unmet needs? Now, again, these are parent-reported dental health status. The parents reported on this. The survey was in English and Spanish, so incorporated most of the population. Then, our independent variable, basically what we wanted to look at was what's the difference between health insurance coverage between Medicaid and private insurance. We also, for the model, we control for all these other variables. We use the child's demographics and also the parents' characteristics, so parents' education level, the income levels, and the general health status as well. So what did we find? We found that if you look on the left side, we looked at the two indicators, the preventive and any dental services. Now, this is basically odds ratios. These are adjusted odds ratios. What you see is there's no difference between public and private insurance children because it is close to 1. It's basically almost equal with the confidence interval overlapping. Now, when you look at the teeth condition, now moving on to the oral status indicator, excellent to very good status was seen. It's 0.77. Basically, it's saying that the private insurance was kids who are privately insured had better oral health status, like were reporting excellent to very good health than public insured. But dental problems were more higher amongst the publicly insured individual children. Now, we also stratified this by age group. We wanted to see how it differed. Now, what we found was preventive dental services, any dental services remain basically the same, but amongst the age group between 1 to 5 years old, they had a higher utilization of dental services amongst publicly insured, amongst Medicaid kids. Now, but the same thing, if you look at the dental problems, as the age increased, you see significant problems in these age groups. The same children who utilized more services or had equal service to privately insured children, they had more dental problems as they grew older, like in their adolescent stage. So what does this finding mean? Again, our key finding was receiving equal dental care utilization does not mean that their oral health status is improving. Now, what are the possible reasons that we can come up with? It's maybe the difference in reporting and parents' perception. The parents' perception of low income versus high income, the way they report on their children's oral health status, the amount of information they have on their own kids on their oral health status. A second possible reason could be the dental care provided could be insufficient. Basically, because they had more dental problems from our results, they might need more dental care utilization, more dental care. Now, the third thing could be dental care utilization is not a good oral health determinant by itself, because it does not incorporate the environmental factors, the socio-demographic factors. So maybe we need to look at a different outcome to look at how this is improving, utilization is actually improving oral health. Now, a word from Dr. Edelstein, what he says is that existing dental care delivery system might not be sufficient. He says that dental care should be mixed with other providers, using besides dental professionals like hygienists, like dietitians, and other medical professionals. By incorporating them, maybe we could increase the care and utilization and improve a child's oral health status. Thank you.
Good morning, everyone. It's a pleasure to be here. I also would like to thank Alan and Dr. Manski for this outstanding issue dedicated to oral health. I think some of us had been waiting all of our lives for this moment, so just take a moment to recognize this. It's great to be here and to see everyone of you in the audience who bring all these different perspectives of how we're going to address this important issue. I'm sure you're all just as eager to find out what our study discovered, but before I do that, I wanted to start with why this matters, why going to the emergency department is an issue we need to talk about. I was finishing my pediatric dentistry residency in the University of Maryland, and we'll never forget the call at 3 a.m. in the morning about a patient who showed up in the emergency room, and the medical team was trying to figure it all out. Luckily, he ended up in an emergency department who had me on call, and I could show up there and do a proper evaluation and treatment. But that's not the case for many emergency departments. Patients show up and our medical teams are overwhelmed with true emergencies. And I would like to really echo what Dr. Manski said. There is a proportion of cases that belong in the emergency room. These are the medically compromised patients. These are the patients who have cellulitis, life-threatening conditions. But what you will see in the Kentucky study is that most of the utilization came from very low severity, highly preventable diseases such as dental caries. Okay, and what happens usually in these scenarios, patients show up there, they don't have, they cannot be properly evaluated, but the medical team needs to do something about it, so they walk out of there with an antibiotic prescription and an opioid, and $800 later, you and I paid for that prescription. So I would like to acknowledge my co-authors, Jane Grover, who is in the audience from the ADA, and Dr. Compton from the DentaQuest Institute. And the next slide is here. So here is the problem. I just described this to you. The settings for proper care for dental conditions is on your left side and not on the right side, right? We don't have the tools for proper evaluation and treatment of these patients in the emergency department. And just to put this in perspective of where I think it fits into the whole healthcare spending, we have about $765 billion in waste. And if you look at that waste categorized, I would say that we're in the inefficiently delivered services, because we can all agree this is not an efficient way to deliver the oral health care to these patients who need it. So let's look at the study. Over the last 5 years, Kentucky spent about $11 to $12 million a year in treating or evaluating dental conditions in the emergency department. But what's interesting is who paid for it, okay? So here we go. This is the private payers as part of it. You see that? And this is what happened with the Medicaid proportion of that payment. Very stable, 19% for 2010 to 2013, and in 2014, dramatic increase to close to 50%. This is Medicare. We already heard from one of our presenters. Medicare doesn't offer dental benefit. That doesn't mean they don't pay for dental care. They do in the emergency department. These are millions of dollars that potentially could be used to fund that benefit and provide the beneficiaries with the care they need. And you can see the proportion of uninsured dramatically shifted, right? Very consistently, about 56% for the last 4 years, and in 2014, only down to 20. The Affordable Care Act worked. Uninsured members, patients, became insured. And this was others. So what are some of these dental conditions? How many did we see? So you see the rate is per 100,000 Medicaid eligible adults, so we adjusted that count, and you have the average cost. And you can see that dramatic increase from 2013 to 2014, additional rate per 100,000 Medicaid. But these are the raw numbers. This is how many more visits we saw. 12,000 more visits in a single year for dental conditions through the introduction of this additional benefit. This is something we need to talk about. The cost of treating this is not going less. It's not going down. It's going up. And these are inflation-adjusted dollars, so you can compare the 2014 to 2010 dollars. The cost of treating this is getting higher, and it's not delivered in the proper setting. This was really striking, and there is something when the data says it's so loud. Gender and race disparities are no evident in any other place than the utilization of the emergency department. And you will see this here. Females traditionally have higher utilization, basically because of the Medicaid eligibility. But what we see that this is consistent through the years, and actually you can see that slight decline, and that shift to completely be reversed by the newly eligible males who entered the Medicaid patients population. And by race, you can see again, we see whites, but also non-whites dominating that. We talked about that this is really the proper setting if they are very sick and they have a lot of chronic comorbidities, but we looked at that. We said, are these patients truly sick? Do they really belong there? And this is what we found. They really are not. So this is, again, through all the years. Look at that. 56 of these patients had 0 comorbidities, meaning they're completely healthy. They don't belong in the emergency room for oral health-related conditions. They need to be properly evaluated by a dentist. 29 had a single comorbidity, and I would argue that the 2 and 3 are probably in the right place because they're chronically complex and medically complex and need to be addressed by a medical team. So again, this trend, if you see that slight decrease, and the slight increase you see with the single comorbidity in 2014 is because for the first time, some of these people have a coverage. They actually know that they have a comorbidity. They didn't know that before. And that's the end of my presentation. Thank you. We'll take questions.
I'm going to start with a few quick questions. Amber, to someone coming at this issue fresh, what I notice, I think many do, is when you're looking at dental coverage, when you're looking at vision coverage, you've got these out-of-pocket maximums. The Affordable Care Act got rid of them on the medical side. The whole notion of insurance, it's really prepaid prevention primarily, and yet here you are modeling a proposal that has a $1,500 cap. And so my question is, are we just so resigned to the notion that the dental benefit design is going to be capped because that's what it's always been, or are there some actuarial reasons in terms of skewing or some selection reasons in terms of self-selection bias that make the numbers not work? Are we just not thinking creatively, or are there actual practical reasons to have the cap?
So I think that with the issue of the cap, it is something that we took from what's existing out there. So there is a certain amount of it's being inherited from what's available. But I think that with this piece, we've primarily written it as a financing piece. But I think whenever we're talking about including different services, we need to be thinking about the service delivery component. And so not encouraging high and unnecessary spending, I think, is a reason that cap is in place. When we were looking at the distribution of Medicare beneficiaries who spent over $1,500, it was 7% of the total Medicare population, and that was, again, steeply gradated by income. So the majority of those people were above 400%, which could have been cosmetic surgery that they'd had on their teeth. It's not clear from the data what that was. And so I think that there is an element of needing to think about what the necessary care is, and that should be what is encouraged and supported through a financing model like this.
Thank you. Brandy, this is sort of a wonky question, but as we continue to get these, the buildup of evidence as you describe of the long-term effects, these are done using econometric models, methods, using population surveys. Are there longitudinal data sources we could start hoping would also give this picture at the individual level as opposed to at the population level? The combination of those two would be even more powerful than the incremental increase of evidence that we're getting from these population surveys.
Yeah, that's a great question. I think that there are kind of a wealth of data sources, as you described, which are these kind of repeated cross-sectional data sources. And so we can use information on the same states over time, but we aren't actually tracking the same individuals over time. And I completely agree that that's a complementary way of looking at the question, which would really kind of bolster the evidence that people are finding using these methods and the repeated cross-sectional surveys. In terms of what data are available, I think that in terms of surveys that measure health, I actually don't think there are very many longitudinal surveys that I know of, aside from the health and retirement study, which these expansions would not have allowed people to get to that age quite yet, those who were affected by these 1980s and 1990s expansions. So I think that's maybe hopefully a good motivation going forward for people to kind of field maybe some of these smaller longitudinal surveys to look at that.
Thank you. Jaffer, you may want to kick this one to Bert, but he's not here. I read the paper and I listen to your presentation and I start asking sort of a basic question, which is equal access the right standard? Or, you frame the paper as it's being met, but it leaves disparities in existence. Does this mean it's time to actually, not just the conclusion that he gave about expanding the workforce, but also maybe asking the question, is this what we should be, is this what our goal should be?
That's good. So there are many outcome variables that you could use actually to determine how the oral health status is improving. Now, just using one to define, like, is this just using one definition or one variable to define a child's oral health is not the only way. So the lagging with coming back to the data sets that we have right now, and this is also a population-based data source, not many people ask those questions, multiple questions. Now, we try to make the best of what we have and try to interpret this, but I think going forward, I think it'll be better if we include more questions like detailed variables that actually incorporate these social and other factors that we could use.
Thank you. Natalia, we've heard a lot about the limitations, things that aren't as good as they should be. Going back again to where Rich started this morning of an opportunity for rethinking, if you were to give a message out of Kentucky, is it, the glass is half full in the sense that maybe what we didn't do everything, but boy, did it do a lot? Or is it half empty as in we did some things, but what I mostly notice is what we didn't get done? What's the overarching to those who are trying to, if you will, start fresh in their thinking about coverage?
Great question. Excuse me. I think Kentucky did the right thing by adding the adult dental benefit. And Marko's work has shown that Kentuckians have one of the poorest oral health in the nation. So that absolutely was the right thing to do for the patients. What I think could have helped these patients navigate the system is some care coordination efforts.
of how they access that system.
Thank you. We do have a little time for your questions as well. And once again, if you'll get my attention, we can get a microphone to you. Go to Jim, who will up here in the front.
Thank you, Alan. Jim Crall at UCLA. Jaffer, I'm interested in the sort of the conclusion about the equal access provision because as Marko's work and many others have shown, Medicaid is not monolithic. If you look across the states, there's wide variation in terms of utilization still, despite the overall improvement over 20 years. So I think the interpretation of the equal access provision, whether we have measures to really sort of draw that out and make judgments, I think is important. Clearly, changes have been made and improvements over time, as you noted, in closing that gap. But sometimes that comes through advocacy, sometimes it comes through some other form in the political process. Sometimes it comes through the judicial branch of government. So, just a comment or, on that and any kind of a response you might want to add about the variability across states. When you kind of smush it all together in a regression analysis, it comes out with a point and a confidence interval. But as others have shown, a lot of variation across the state. And as we move forward in the new political time, to think about states having more role or maybe a stronger role in making those decisions, I think that's an important policy consideration.
Thank you for that question. It's great. You're right, because states are different when it comes to it, and this survey does incorporate the different states, and we did see some variability, but we just wanted to focus on a national level. We did not go at the state by state level, again, because what you're doing is you're taking a sample and you're trying to, though it is a representative of the whole national population, that's how they survey the individuals, it's still not like, you're just still taking a sample to go and represent the whole state by itself. Now, coming to the point that using you said about like using different variables, different outcomes. That's the biggest limitation that we have. We don't have enough indicators or different indicators to actually compare it to look at it. We do have in the field of gums, like they do ask a lot of questions like, did you lose your teeth or do you lose your, again, these are parents' perception, correct? These are surveys. So, but when it comes to dental, just by looking at for kids, they have less of gum disease compared to more of the dental caries. So those questions are valuable when it comes to the periodontal part of it, but when it comes down to for kids, we don't have enough indicators for it. So, yeah.
Well, I want to save enough time for our panel on workforce, so please join me in thanking this panel. And I would ask our final four to come up. We'll move into this and just to keep us moving so they have maximum time, I'll go ahead and begin introductions as they're making their way up. I do want to assure that there's time to get through these papers that all focus on various aspects of the design and utilization of the workforce. Margaret Langelier is Deputy Director of the Oral Health Workforce Research Center at the Center for Health Workforce Studies in the School of Public Health at SUNY Albany. Jane Koppelman, Research Director for the Pew Charitable Trust Dental Campaign and former Deputy Director of the Robert Wood Johnson Foundation's Making the Grade program, which focuses on school-based health centers. Jim Crall, who just asked the question, Professor and Chair of the Division of Public Health and Community Dentistry at the UCLA School of Dentistry and Director of the HRSA Maternal Child Health Bureau Leadership Training in Pediatric Dentistry program. And of course, you've already met Beth Mertz, Associate Professor at the University of California, San Francisco. So I will turn it over first to Margaret.
And show me where I'm pressing right there.
The right.
The right one, thank you very much. So good morning, and I'd like to echo the thanks of the other authors to Health Affairs for allowing us to present our work on various aspects of oral health. I'd also like to thank my co-authors, one of whom is here today, They are Tracy Continelli, Jean Moore, the executive director of our center, who's in the audience, Bridget Baker, and Simona Serdou. So as you've heard this morning, stakeholders are increasingly recognizing the importance of engaging a comprehensive oral health care team, including everything from community dental health coordinators and community health workers to general and specialty dentists, in order to reduce the burden of oral disease in the population. And as a result of these emerging strategies, this creation of oral teams, the roles of dental hygienists are changing significantly from the traditional role as a dental extender to a much more comprehensive role as a preventive oral health specialist. In many states, dental hygienists are permitted to practice in public health settings under much lower levels of supervision and with some greater autonomy to determine the need to provide preventive services. Still, because of variation in scope of practice across states, in some states, dental hygienists mainly practice under direct dental supervision in community settings, which in some ways creates barriers to preventive services, especially for underserved populations. So in 2001, the Health Resources and Services Administration asked our center to create a numerical index to quantify variation in scope of practice across states. We had done this exercise for nurse practitioners, physician assistants, certified nurse midwives, and they wanted a similar one for dental hygienists, partly to use as a tool to answer the question, do expanded scopes of practice, collaborative practice, public health supervision really matter, and do they affect either utilization or outcomes? So in 2001, we created the Dental Hygiene Professional Practice Index. I'll call it the DHPPI. It's a numerical index. It's constituted of more than 40 variables, each carrying a weighted score relative to the impact of the particular variable on the ability of a dental hygienist to provide preventive services in the community. I'm sorry I couldn't present the instrument because it's very long, but I refer you to the technical report, which is on our website, that contains all of the individual state scores for each of those variables. So these variables were grouped under 4 categories. They were grouped under regulation, supervision, tasks, and reimbursement. The optimal score was 100 on the total instrument. In 2001, state scores varied from 10 in West Virginia to 97 in Colorado. We did some regression modeling with an oral health outcome out of the BRFSS and found that, in fact, dental hygiene scope of practice in states was positively and significantly associated with higher utilization of dental hygiene services. So in 2014, again with funding from HRSA under our cooperative agreement as the Oral Health Workforce Research Center, we rescored the 2001 instrument. Using state law and regulation, this is totally scored on what is possible in a state, not what actually happens, but using state law and regulation to create the scores. And what we found was that composite score changed from rose from a low of 10 previously to a low of 18 in Alabama and Mississippi to a high of 98 in Maine. Now, the map here will give you a general idea. I'm sorry it's so small, but it will give you a general idea of the distribution of the scores on the instrument. The light pink, or what appears to be gray, are the lowest scoring states. The darker blue or purple are the highest scoring states with the most permissive scope of practice for dental hygienists. The mean on the instrument progressed from 43.5 in 2001 to, I'm sorry, I've got to look this up because I have so many numbers in my head. It was 57.6, is that what I have there? In 2014. And the greatest progression occurred in the supervision category, where the mean progressed from about 19.1 to 27.3 on a score for that category of 47. So over time, states had changed their required supervision in public health settings, allowing more practice to more hygienists. So the next thing we did was we did exploratory and confirmatory factor analysis on the instrument to ascertain that the 4 groups of variables actually constituted a single construct, in this case, the overarching concept of scope of practice. And once the validity of the measurement instrument had been established, we did some multi-level modeling to understand, once again, the impact of scope of practice on an oral health outcome in the population, in this case, tooth loss due to decay or disease. We use this variable from the Behavioral Risk Factor Surveillance System, which is a nationally representative telephone survey of a large sample of the U.S. population, and it is representative at the state level. We controlled for a number of state and individual level characteristics, including community water fluoridation, the rates of dentists and dental hygienists, and the socioeconomic and the demographic characteristics of the individuals in the state. And we once again found a positive and significant relationship between dental hygiene scope of practice and an improved oral outcome in the adult population only, because that's all that is in that sample, represented by a lower rate of reduced tooth loss or decay. So briefly, I'll close with why is this important? Policymakers are really thinking about workforce strategies to increase access to services. And scope of practice always arises as an issue because it creates barriers to access, especially to preventive services. So we suggest that perhaps placing dental hygienists in public health settings may have a long-term impact on not only utilization of preventive services, but also on navigation to dental treatment. So thank you. I encourage you to look at the report and the technical appendix that's included to look at our methodology, and also to access our website to see the much longer and relatively boring iteration of every single state scores. So thank you.
Thank you. Everything? Yeah, okay.
Oh, I'm sorry, I didn't move it on.
There we go. I want to acknowledge my co-authors, Lisa Simon at the Harvard School of Dental Medicine, and Kelly Vitzum, who at the time of when we wrote this article was at the organization in Massachusetts, Healthcare for All. We wrote about dental therapists, kind of providing an update. Dental therapists are mid-level dental providers, and they're used to, or they have been used around the world and in the U.S. to expand access to care for underserved populations. So what we did in our article was provide an update of what we know, how dental therapists are currently being used in the U.S., an update on the research speaking to their effectiveness and a business case. And we take a look into the future and kind of ruminate on how healthcare transformation and new incentives in the healthcare market may create quite a demand for provider type like dental therapy. So basically, first, the problem that dental therapy seeks to address. There we go. It's access to care. And we know that tens of millions of Americans, mainly low-income, racial, ethnic minorities, have a serious problem accessing dental care. We know that there are a myriad of factors that are responsible for or are fueling the access problem. One of them is cost. But we also know that another factor is a maldistribution of dentists around the country that cause shortages in thousands of communities. And the dental therapist provider gets at this second problem. So very briefly, to provide some picture of what we see as, or what is emerging as an access problem, we've got more than 48 million people living in areas of the country that the federal government has deemed has a shortage of dentists. We also know that very few dentists participate in Medicaid. There are a variety of different estimates. We know that in 2013, ADA did a survey of dentists, and they found that about 2/3 did not treat any patients who were on public assistance. So that is creating an access barrier. We also know that there are certain people, people with disabilities, certain disabilities, children, elderly, living in nursing homes and assisted living facilities that have problems getting to an office or to a clinic. We have a dental care delivery system that's not quite flexible, and so there are access problems for this group. So I want to briefly talk about how dental therapy or a dental therapist, at least in the U.S., is addressing these various problems of shortage areas, of dentist disincentives to treat Medicaid patients, and kind of a rigid office-based delivery system. And again, very briefly, what do dental therapists do? Their role is kind of similar to a nurse practitioner or a physician assistant in medicine. They provide preventive and routine care. What distinguishes them from most other dental mid-levels is that they can drill and fill teeth and perform non-surgical extractions. These are procedures that have traditionally been within the sole purview of dentists. And in the U.S., they always work under the supervision of a dentist. They don't hang out their own shingle. They're trained to do maybe about 45 procedures compared to a dentist is trained to do about 500 procedures. So while this is a fairly new provider type in the U.S., about 54 other countries have been using dental therapists for almost 100 years. So you find them in the UK and Canada and Australia, New Zealand, the Netherlands, and in these particular countries, they're working as they are in the U.S. in both the private and the public sectors. So let me talk a little bit, provide an update about how they're being used in the U.S. They're just really in a few states now in the U.S. So in Alaska was the first state to use dental therapists, not statewide, but to treat, to care for the serious problems, oral health problems of Native Alaskans. So in 2004, they started in Alaska. And what Alaska did was they've got a huge problem with very, very remote villages where dentists, maybe they can visit once a year, maybe twice a year, maybe they don't get to a village in a year. So they are deploying dental therapists to either rotate in and out of these villages or to actually stay in these villages and provide care. Right now there are about 35 dental therapists in Alaska. In Minnesota, they've been working since 2009, and private dentists are actually using them, and they're finding that it's more feasible to accept Medicaid patients because of the low discounted rate that Medicaid offers. The lower cost of a dental therapist, and in Minnesota we're finding that the hourly differential ranges about $30 per hour in a salary differential. It makes it more feasible to accept Medicaid. Public clinics in Minnesota are using dental therapists to expand access to more uninsured and more people on Medicaid. Some public clinics are taking these dental therapists and they're putting them in nursing homes. They're putting them in public schools to get at the folks who have problems traveling. This is a very brief overview of the states that are now actively considering dental therapy legislation. Those states are in gold, I would say. So basically, I wanted to talk about growing political momentum. Health affairs is about policy and practice and research. It's very difficult to talk about dental therapy without talking about politics, because this has been a scope of practice issue, and as many of us know, scope of practice issues can be very contentious. As we've seen in podiatry and ophthalmology, it's there in dentistry. So basically, in order for states to use dental therapists, you need to change your state dental practice act, and that takes legislation. The The legislative debates so far have been difficult and they've been long. Dental therapy has been authorized in Minnesota, in Maine, and in Vermont. And they've all been very, very contentious debates. There's something that's worth noting, that the environment for these legislative debates appears to have changed in the past couple of years. And I just wanted to talk about a couple of things that have changed. The Commission on Dental Accreditation issued national accrediting guidelines for dental therapy training programs. This has represented kind of a major breakthrough. Institutions now may have more incentive to develop training programs. You need a pipeline for a new provider type. And legislators may also feel that, there's more support to get behind this model. I wanted to briefly mention looking into the future. There are some political forces that are happening now that are making these legislative debates easier. By the way, one of them is that free market advocates are enjoying the dental therapy model. They see it not as so much as an access to care issue, but as a commerce issue, that dental offices are small businesses. They should have the tools available to them to increase their profits, to increase their efficiencies. But looking to the future, we think that there are a number of things that will create a more of a demand for dental therapy. One is the growing part of our health system that is being managed by accountable care systems. So when you have global budgets, when health plans are actually on the line and face financial risk for meeting utilization measures and quality measures, looking for efficient cost providers, efficient lower cost providers, there may be more interest for that. The other thing that we're seeing that was mentioned earlier, dental practice consolidation. The number of dental practices with more than 100 dentists has more than tripled over a certain period. And we know that these large practices use dental auxiliaries. They use them because they improve efficiency, they can get more volume in, so there may be more of a market for dental therapy there. Finally, again, what was talked about earlier, medical-dental integration. And when that is done at the very grassroots level, we think of locating dental providers in medical facilities and having a lower cost provider that can treat dental decay, and being able to station them in a pediatrician's office or a geriatrician's office may become quite attractive. So, read the article.
I'd like to start off by thanking Health Affairs, including the editorial staff and the reviewers who helped to shape these papers, and acknowledge my co-authors, Dr. Natalia I with the UCLA Center for Health Policy Research, Maura Inglis with the School of Public Health there, Colleen Lampron and Richard Scoville, who were instrumental in directing and providing quality improvement advice in our QI Learning Collaborative. I'd also like to thank First 5 LA, without which none of this could have happened. First 5 programs in California take tobacco tax revenues and put them into county-based programs that are geared toward children from prenatal up through 5 years of age. And they have been very instrumental in making these changes. I'll give you a brief overview of what we were facing and what our strategy was, the components of the program, talk briefly about achievements, and then the policy considerations. Really, the primary goals of this program were twofold. One was to increase the capacity of community-based clinics, predominantly federally qualified health centers, to serve as quality dental homes for young children. The second was to actually increase parents' and caretakers' awareness of the importance of oral health in early children, because as we know, we can build it, but if we don't, as Natalia and others really highlighted, we have to help educate the public as well about what services really will put the kids on a good trajectory for health. So we saw this as an opportunity not just to increase services for 53,000 kids, not that that isn't well worth doing, but as an opportunity to really look at could we use this as a model in a laboratory to understand some of the challenges and the barriers, and then to find solutions to improve the situation. This is the context in which we work. Los Angeles County, where we have over 500,000 0 to 5-year-old children on Medicaid or Denti-Cal, as we call it in California, who aren't getting any dental services, right? Over 500,000 just in that county. So we selected clinics, 20 federally qualified health centers that have co-located medical and dental services, because we sought to use not just the dental providers to expand that care, but to use the primary care medical providers and community-based resources as well. And so those are the clinics. We tried to pick those from across the county, and we chose areas that have high concentrations of those children on Medicaid who aren't getting services. The context within the health centers are much like the overall healthcare delivery system. Very busy practices for the most part, generally staffed by general dentists providing care mostly to adults. Very busy primary care practices, treating a wide range of conditions, but doing very little when it came to oral health. In fact, one of our very early findings was that there were 10,000 more children in the first 12 clinics we were working with that are already coming to these clinics and getting primary care services. They're not getting any dental care, even though there's a dental care facility right under the same roof. And that led us to do a little policy work and analysis ahead of time, where we really discovered that if you look at the facility level basis, only 39% of the FQHCs in California have co-located medical and dental services, even though if you look at the grantee level, that percentage is represented as being much higher. But when you get down to the facility level, it's not the case. And that's pretty consistent with the overall HRSA data that shows that only about 1 in 5 individuals who get health care at a federally qualified health center get any dental services there. So our overall strategy, again, is not just to crank out services, because we know that's going to be a short-term, sort of a bump, boost, and then it may go away, but to really sort of look to develop a much more innovative and hopefully sustainable program over time that integrates dental and medical and community outreach services that helps to identify these care pathways that we can channel kids based on their risk of disease and their health status to do care as efficiently as we can. And to then develop these sustainable community linkages as well, because if you believe in the chronic care model and the expanded chronic care model, you know that that's really important as well. So, the facets, because of the generosity of First 5 LA, allowed us to do a lot with these clinics. So we provided some funding so that they could at least contract with a pediatric dentist on a part-time basis to put a pediatric dentist, because there weren't pediatric dentists working here in these programs. So that allowed expansion of services, but also let them be an educational resource for the dental personnel and the medical personnel working in those facilities over time. We used and trained a new worker called a community dental home coordinator, which is along the lines of the ADA's community dental health coordinator, and it varied by clinic whether those individuals actually had clinical experience and could do clinical things or not, but effective all the way. We trained medical and dental providers using a variety of mechanisms. A really important facet, I think, was the QI Learning Collaborative. Based on the Institute for Healthcare Improvement's Breakthrough Series model, we literally worked with these medical and dental and administrative teams and created teams. We had people that had literally been working at the same institution, the same facility for years, parking the same parking lot. They had never met each other. So when you get them together and teach them how to redesign care processes and learn quality improvement, that's where the real change can come, and I believe where hopefully the sustainability can come. And the community development piece we can look at later. During the process of that, we developed what we call a risk-based integrated care pathway. This is in the appendix of the article, so you won't see this in the main paper, but if you click on the appendixes list or link there in the page, you'll see this. And I would contend that this is actually could serve as a bit of a model for the entire delivery system. It's not just about FQHCs, but it helps to outline some of the expectations for the medical care providers, the dental care providers, sets up a real system-based approach to looking at this and emphasizes care coordination, and also emphasizes that the job of the dental personnel is not just to fill the holes in the teeth and take out the bad ones, but it's actually to work on reducing that risk and making people healthy over time. What did we achieve? Clearly, we, over the course of a couple of years, got increases in services. We doubled the service capacity and productivity of diagnostic and treatment services. We tripled in with those clinics the preventive services. So we showed that it can be done. We taught quality improvement to dental providers, and we got them integrated into operations and administration of these clinics and never had before, and we did improve linkages. The policy considerations really, I think, are twofold. One is a physical issue about, in my opinion and our view, we need more co-located facilities because we already have an underserved segment of the population that are coming to these places for primary care, but they're really not getting primary oral health care. And secondly, making these other changes will require support. And so in the paper, we toss out some considerations for CMS, for HRSA, and I want to end on a glass half full note, Alan, to your earlier point. A lot has been done over recent years, the previous couple of administrations in Congress, to increase oral health care delivery in these facilities, but much more needs to be done, and that's our call.
All right, I'm your bookend today, apparently. I am presenting on a second paper that is in the thing looking at underrepresented minority dentists in the United States, and we look at their practice patterns, and that's what I'm going to be presenting on. I want to thank my amazing team and also my co-author, Paul Gates, who's in the audience here today, who was the brainchild behind this whole thing. So thank you, Paul. So just a little bit of background. Minority populations in the U.S. have greater oral disease rates and poorer access to care. We have large disparities by race, ethnicity for oral health in the United States. And we have a big lack of minority health providers as well, not just in dentistry, across all of the professions really, but it's particularly acute in dentistry. The reason that this matters is because there's been multiple reports and evidence that show that when there's concordance between the provider and the patient, you do actually lead to better access, better communication that can then lead to better health outcomes. So in our study, we defined underrepresented minority dentists to include Black dentists, Hispanic or Latino dentists, and American Indian and Alaska Native dentists. The policy approaches to improve diversity in the workforce that have been used include a whole list of various things. So there's no lack of policy approaches to address workforce diversity. We have mentoring programs, pipeline programs, all focused on recruiting people into the pipeline to dental school. We have dental school admissions policies to try to improve diversity. And then on the other side, we have scholarship and loan repayment programs and other sort of more structural grants to try to get institutions to do this work, as well as the licensing of foreign trained providers as another final mechanism. So lots of different policy approaches. So we think across all of these policy approaches that have been in place for many years, the cumulative impact of those policy approaches is quite poor. Currently in the United States today, to bring the underrepresented minority dentist population just to population parity, not taking potential population growth into account, would require almost 20,000 Black dentists, over 30,000 Hispanic Latino dentists, and almost 3,000 American Indian and Native dentists. That would be just to bring the dentist population to parity with the US population in terms of racial ethnic mix. To put this into context, we graduate about 5,000 dentists per year from our dental schools. So we would have to graduate 10 years of only underrepresented minorities from every dental school in the entire United States just to get to parity today. Our study used a national sample survey of minority dentists that was completed in 2012, is the first and only ever sample survey of these providers. And we really wanted to understand what their contribution to care was. We know there's this huge gap, but what's going on with the folks that are out there? The first finding, we found a very strong patient-provider concordance. Black dentists, on average, saw 45% of their patients were Black. American Indian, 20%. Hispanic Latino, 41%. And among all of our URM groups, on average, their patient population, just of the mix of underrepresented minority dentists, was on average 54%. So these providers are seeing a very disproportionate share of minority patients in their practices. We also know, and this is in the context of understanding that these groups have already access to care problems. To further look at this concentration, we looked at the percent of dentists in relationship to the population and county percent. So what we see is all of these really essentially show you the concentration. So the dark bar tells you the percent of dentists in the country, so about 3% of dentists in the country are Black. On average, about 18% of the population says they're Black alone or in combination, according to CPS data. In the counties where Black dentists work, it's on average 26% of the population is Black, and as I said before, almost 45% of their patient population is Black. So we're seeing not only are they living and working in counties that have a concentration of minorities, even within those counties, they're seeing a much greater concentration of minorities in their practices. The third key finding, what we did here is we compared counties that have a minority dentist with counties that don't have a minority dentist, and then we sort of statistically tested the difference between those. And we found significant differences across all of the variables that we looked at. Where there is a URM dentist, there tends to be a higher underrepresented minority population, a little bit higher median income than where no minority dentist is, more dentists per capita, but also higher income inequality and higher residential segregation. So you're seeing two things that are happening here. One is that most of these dentists are private practice dentists, and they need to work where they can make a living. So they're not working in the poorest and in the most low-income places as private practitioners because they can't, and neither can anyone else. So, however, we do see that they are concentrating in communities with higher income inequality, residential segregation, lower English proficiency, and so forth. The final thing that we looked at, we asked information about what motivated their practice when they went into their initial practice choice. And the service to their own race ethnic group was, one of them is now missing off of this. So there's two. A factor influencing their initial practice choice, about 40% said service to their own race ethnic group, and the blue bar, which I apologize is the light blue bar, is service to underserved populations. So you can see that about a third are saying that it's a factor influencing their practice choice. More say that it's a factor influencing their actual job satisfaction. But then when you go back to the dental school, why people go into dental school, many more people say that it's a reason they went into dental school than it's a reason of why they actually chose their practice choice. And the things that actually do influence their practice choice is where their family lives and how much money they can make. So just to close, in terms of what we found that there's a daunting shortage of minority dentists and that we really need a deeper and wider pipeline. There's a lot of policy initiatives already there. They're clearly not having the impact cumulatively that we're looking for. Underrepresented minority dentists, they locate in high minority communities, and their patient panels reflect the concentration of minorities even within those communities. And they have a very strong service motivation, but aren't always able to make that into action because of just the general practice economics and some of the delivery system issues that we've talked about already today. So in conclusion, when we think about improving diversity in the workforce, it really is an endemic problem in the health professions, but there's sort of two approaches you can take. The default approach is sort of assuming that minority providers will be the minority access solution. And it is true that they're a critical part, but more must be done to address structural inequalities. It's unfair to ask a group of people who are already systemically discriminated against and already have a very small amount of the workforce to be responsible for these huge oral health disparities. So a more designed approach that we think is really rooted in social justice that looks at an approach of reform of the delivery model with diversity and inclusion as a core value that's infused into dental education, infused into the financing, and infused into organizational design. And finally, just speaking to the political context, reports over the last 20, 30 years have noted this problem and have come up with many wonderful evidence-based solutions. The political will is really what is lacking to move us into a place where we have oral health parity that can then support the kinds of providers and the kinds of organizations that we need to address all of the issues we have, including workforce diversity. So thank you very much.
We're very short on time. I'm going to ask quick questions with hopefully some fairly quick answers. Margaret and Jane, both of you talked about changes that require political action. And there's a reference earlier today, as well as in the presentations, about sort of free market principles as a motivation for loosening up some of the restrictions on scope of practice. It's hard to look at either of your maps and line those up very well with places where one thinks of free market principles as being the dominant political ideology. So I just wonder, is this a true opportunity, or is this sort of a rhetorical opportunity? Not to put you on the spot or anything.
So in 10 seconds, I think that there is, what's happening in state legislatures, frankly, is that there's been very strong lobbies against scope of practice expansions, and there's growing recognition that the oral disease burden is not improving in the population. So I'm seeing that advocates and others are having much more leverage in state legislatures on advancing scope of practice for a number of reasons. Some of it is the move to accountable care, value-based care, capitated care, the influx of new Medicaid insured that are in need of lots of services. So while it's very difficult to predict what legislatures will do in the coming 4 years, my suspicion is that scope of practice will be something that legislatures will really consider as important. One of the things that we're noticing is that the dental therapy models are often using dental hygiene now. In Minnesota, they did have 2 models, one which was not foundational in dental hygiene, but now they're only doing the ADT. Both Maine and Vermont require preparation as a dental hygienist. So, legislatures are being thoughtful about it. It's coming up. It's not getting necessarily the traction it needs to pass, but we're seeing these movements gaining momentum. So it's and they are cost effective. So in a free market environment, it may be that we'll see some acceleration in legislatures passing these kinds of. And I'm sorry, I took most of the time.
No, very briefly. It is hard to predict, but we have seen in the past 2 years events like Grover Norquist testifying before the North Dakota legislature in favor of dental therapy. We know that free market think tanks like Cato and the Mackinac Center and a variety of state-based centers are now writing issue briefs saying there's no reason not to have this. And again, it's an anti-competition and a free market look at what has traditionally been access to care, social justice issue. It's fascinating.
So maybe it's an emerging line that hasn't yet all played out. That's very helpful. Jim, there was a lot this morning about financial incentives, financial alignment. You spoke much more about organizational, professional. Is there a financial element or a component to the backdrop of the FQHCs that's either an impediment or a motivator for the kinds of integration at the clinical level that you all were trying to achieve?
I think yes, Alan. The big picture is that it's a different financing mechanism. It tends to be on cost-based and the recovery for cost of uncompensated care, and that's all baked into the encounter rates that many of the health centers get paid on. I think where finances becomes really important is in making sure that that those costs, and particularly of new we're talking about workforce here. If you're going to put a new provider into that mix, like a community dental home coordinator or a specialist for primary or pediatric dental care, that needs to quickly get put into the system. And the bigger barrier, I think, is the concern that we heard, and it's mentioned in the paper, about health centers opening up the liability if they have their cost basis re-looked at again, and that may sort of stymie innovation and creativity. So I think that, doesn't mean that there can't be innovative ways to do that, hopefully through some demonstrations and adaptability in different systems over time. I think health centers that are facing and looking to the future and see themselves being much more part of the managed care landscape are seeing change coming, and they're trying to prepare themselves for that. But there definitely are some sort of structural or historical formulaic issues that need to be addressed as well.
So that's a good transition, Beth, to the question I have for you. Since I'm asking everyone to speculate, this really falls into that category as well. But you described survey data on attitudes that include perspectives of social justice and return to the community. But I'm struck by much of the conversation and much of the sort of the national conversation is about this realignment of systems, incentives, integration with medical and whole person care, patient-centered care. I wonder if there's another pathway to the distributional issues that you describe, which isn't just around social justice, but is around a broader perspective of the role that the dental community can play in improving population health. Is that part of the conversation, or am I just out off base asking about that?
No, I think it is. I mean, I guess I would say, in the past we've had this system where dentists just kind of go out and do what dentists do, and there hasn't really been a system. And so we've seen the minority providers have gone back into the minority communities, and they don't go into specialists as much, and they tend to be employees more. I mean, and they tend to go into armed forces as more. I mean, all the things that don't surprise us. But then the question becomes, well, there's so few of them to start with, and then we have this minority health problem, and I guess they'll just take care of it. And that's just wrong. And so what you're doing is you're putting folks into a system that fundamentally can't. I mean, if you have a large urban population that has no dental insurance, just because you have a black dentist there doesn't solve that problem and doesn't make that dentist, I mean, it actually repeats the cycle of discrimination by that provider then has a lower income and then has a lower, and so, I mean, those are the kinds of things that we need to think about where we're doing system reform, and we're saying, how do we create a system that provides equal opportunity for everybody, both to walk in the door and get services, as well as to get educated and become a provider at whatever level that is that they want to be, whether it's a hygienist or a dental therapist or a dentist or a community health worker, so that we create those systems that really values that workforce diversity and encourages that workforce diversity rather than sort of segments and just, relies on the continued social segregation and socioeconomic segregation that we have that actually perpetuate those patterns over time. I don't know if that answers your question, but thanks for letting me say that.
I think you got your answer. That's we really do try to adhere to the time that we've designated because I know people are busy. I'm going to call us to a close here with the hopes that those of you who have individual questions for the speakers, you can find them after. I just, as we wrap up, want to again thank the California Wellness Foundation, DentaQuest Foundation, American Dental Education Association, the Reach Healthcare Foundation, Washington Dental Service Foundation, Gary and Mary West Foundation, American Dental Association, Health Policy Institute, Pew Charitable Trust, and the St. David's Foundation for their support. Note that our next release event will be February 7th, an issue focusing on workplace health. Please join me in thanking our last panel for rounding out the day.